The keywords are threat, danger, so the experience, the appraisal of threat and danger.
How is it different from fear?
Okay, that's been a long-standing debate, and to try to make things simple, many people do not make that distinction and think, well, it doesn't really matter whether you call it fear or anxiety. Others are more peculiar about the distinctions between these two terms. So if we want to make some distinction, fear usually refers to a more biological phenomenon, so something that's also often referred to as fight or flight reaction. So you perceive danger, imminent danger, and you need to do something straight away. You usually either fight or flight. So that would be a classic type of fear, right? As opposed to that, anxiety is not that clear cut. It's more vague. It's more sort of up in the air. It's that unpleasant feeling that people describe in many different ways. And it usually does not require an immediate response. When people are anxious, they do not have to fight or flight. So that's one distinction between anxiety and fear. The other is sort of related to this in the sense that the object is fear is usually well known, it's clear cut, so people are afraid of animals, afraid of heights, afraid of flying, etc. Whereas when you ask people who have anxiety, typical anxiety, some of them wouldn't be able to be so precise. They would say, well, I feel anxious, I'm not exactly sure what it is about. It's just that very unpleasant feeling, I worry a lot. But they would not necessarily be able to clearly explain to you. Now, these are sometimes very, very crude distinctions. In clinical practice, we see people who have a combination of fear and anxiety. Maybe that's a too long response to your question.
I think because he's come from the University of Belgrade, we'll give him a little bit more time. What do you think? One more question for you before I move on. And all through the night, we'll have snapshots of information and you will knit it together into a cloak for yourselves. But what's the link between anxiety and depression?
It's a very significant link. Let's say roughly one half of people with anxiety experience depression and vice versa. Of course, studies differ in terms of the percentages, but very, very often people who have one condition usually have another. That's what we see in clinical practice all the time. Sometimes it's even difficult to say whether anxiety is primary or whether it's depression. There is sometimes a view that depression is more likely to be a consequence of anxiety, that anxiety is something that starts earlier in life and then depression develops later on. That is a more common scenario, but it doesn't necessarily have to be the case.
Look, thank you. I guess the one other thing I will ask you before I move on is, how do you know when it's serious enough, whether you're feeling anxious or depressed or a bit of both? How do you know when it's serious enough to seek professional help?
Yeah, of course, that's an excellent question. You know that it's serious when, just very broadly, when this interferes with your life in various ways. For example, you're unable to work or your work productivity is lower than normal, you are unable to study, you have disturbed relationships with your partner, with your children, with your family. So when there is a problem of that kind, so we call it functional impairment. So when you feel that depression or anxiety or both have interfered with your life in a significant way, that's a clear sign that that person needs some kind of help, and that's when they usually seek help.
Julie, do you want to come out, please? Julie has been kind enough to agree to share some of her own personal experience. If you wouldn't mind standing to the right of me, and we welcome our videographer who was running a little bit late but who is present and is filming us, and that's why I'm asking people to come into the light. But when I come to question time, you don't have to come out the front, don't worry. Julie, I want to focus on recovery, but first of all, how did you know something was wrong? What made you think something was wrong?
I couldn't do anything. I was completely debilitated by OCD, and I had it from the age of 5.
And what is OCD? What does that stand for?
OCD is obsessive compulsive disorder, so people get a bad thought, and then they get the anxiety, and then they usually do some sort of action to alleviate the anxiety and the thought. And that could be washing, tapping, checking.
And do you mind telling us a couple of things that you did?
I could be here for a year. I did lots of things. I was a checker, a washer, counted, did all sorts of things. Mine was always to do with if I didn't do everything perfectly, someone in my family would die. So I had this overwhelming fear that someone would die, I'd cause them to die. So at my worst, I'd be checking windows and doors for hours and hours, washing my hands for hours at a time. And then when I got really bad, my husband used to get me up, he'd shower me, he'd dress me, he'd put me in a chair, and that's where I'd stay all day until he got home, because the thought of having to go to the toilet and wash my hands for 3 hours or check a window or a door was just too much.
How are you now?
I'm fantastic now. I had treatment probably about 27 years ago, finally found out what I had. I was 30 before I found out what I had. Now, like most people, I can just pick up my keys, my handbag and walk out the door. It's fantastic.
How does that feel?
It's just, it is really liberating, and it probably took me a few months after treatment to realise that I had my life back. But it's just having your life back, being able to go to the movies or go to a dinner or just go to work.
Now, obviously, there's likely to be someone here who has either experienced this or has someone they care about who has. Are you able to tell us the 2 or 3 key things that helped you to address that challenge?
Finding someone who knew what I had. I'd been to a psychiatrist for 2 years every week, and I told them about checking, washing, cleaning, counting, all the bad thoughts, who said, didn't know what I had, but obviously something happened in my childhood, which I don't think did. My husband read it in a women's magazine of all things, no Google in those days, and he brought it home and read it to me and said, I think this is what you've got. They're doing what you do and you do what they do. I went to see the doctor and it just changed my life. I did treatment every day for 3 weeks.
So the first message I'm getting is find the right, find a clinician you're happy with who's got a diagnosis and a plan, probably. So what did you do when you say treatment?
So I did cognitive behaviour therapy. So because my thought was always to do with death, he had to prove to me that it didn't matter what I had to do with death, I couldn't cause somebody to die. Back in the days before treatment, if I went to a funeral, when I came home, everything I was wearing was put in the incinerator because I thought if I wore them again, somebody would die. So that's how strange it is. So every day we went to funeral parlours, we went to cemeteries, he took me to the morgue. We did anything to do with death to prove that just because I'd been at a cemetery, nobody in my family was going to die.
Anything else that helped?
I think just support of my family and him in particular, the doctor. I think that's purely it. Probably about 3 months after treatment, I used to say to him, I don't know anyone else with this. I don't think anyone has it. I'm the only person in the world. And he said, for goodness sake, I'm going to speak at a support group in 2 weeks' time. Come along. And it was the most fantastic feeling because there was about 35 people there. And someone might say, I washed my hands for 2 hours, and no one said why, which is what people would say to me if I told them what I was doing. They all just nodded. They understood. And I continued to do it, and I've been running an OCD support group for 27 years. So support groups are great because you can go there and speak openly.
Because I was going to ask you, how do you maintain your well-being? So why are you still well?
I think it was the treatment. But running the support groups, and I also work for Way Ahead, which is the old Mental Health Association of New South Wales, and I'm on the information line. So not every call, but every now and then I'll get a call or someone that comes to the support group and I think, oh, that sounds just like me. And I think that keeps me on my toes. And if I do have an urge to check something or wash or something, I think, oh, no, I don't want to go back there. Because I truly believe, and I'm not going to test it to try it out, my theory, I think if I just started to check the stove or the door or something, I think it would all come back. I think it's that strong.
My one last question is the role of the family. So what impact do you think you had on your family when you were unwell, and then how did they help you?
My poor husband, I kept it secret from most people. My poor husband suffered terribly. I involved him in all my rituals. As I said, we didn't know what it was, so we just thought I was peculiar. So I would check windows and doors before I went to bed. I'd make him check. We lived in a 2-story terrace. And then I would wake him up through the night. And this is terrible, but it's emotional blackmail, and you do what you can do to get someone to help you. So I would say to him, I'd wake him up 3 times a night maybe. Dennis, we just go down and check the front door. I've already checked it. If you love me, you'll check it again. Because I had to get rid of that anxiety. So he was told the first day of treatment, he drove me into treatment, he was told, as of this very moment, you stop doing anything that's to do with Julie's anxiety, and that's my rule. That was the doctor saying that. So it was good because I could be on the floor begging him, please, just check the door once, and he'd say, I'm not allowed to. So I think that helped because he had to be strong, and I just had to do the homework.
May I ask, do you have children?
I do now have a daughter, yes.
But not at that time?
No, I don't think I would have been able to cope.
Thank you. Really, thank you. It's a really big deal to be able to hear. I'm going to come now, if I may, to Associate Professor Melissa Norberg, Deputy Director of the Centre for Emotional Health at Macquarie University. Melissa is a clinical psychologist and she teaches at Macquarie Uni. You are involved in action to help people stop behaviours they don't want. So as you listen to Julie's story, what are your comments? What messages have you taken away from that?
So my message for Julie, that highlighted it quite well, is avoidance is one of the key underlying problems with anxiety. In the moment, it feels like it's protecting you. So if you are afraid that those clothes, if you take them into your home, are going to kill someone and then you incinerate them and no one dies, it teaches your brain, well, they only survived because I burnt my clothes. And so that fails to teach you that the opposite doesn't happen. If you wear them, no one dies. It also teaches you that you can't tolerate anxiety, that the only way that you coped with it is because you threw those clothes away. And so what I work with people doing is to teach them to stop avoiding. And it can be hard at the beginning, and that's why you need supportive people to encourage you and to remind you, you've been suffering with anxiety for 30 years, and so I know you can keep doing it. So let's show you. So let's do some really hard stuff together, and when you're doing it and you're feeling anxious, I'll ask you, so are you dead yet? Are you dead yet? Oh, so you are still coping. You can tolerate this. Okay, well, tell me when you're about to die. Okay, you haven't died. And so by doing those things over and over again, you not only learn that you don't have to incinerate your clothes to prevent death, but you also learn that you can tolerate anxiety. You don't have to like it. That's not my message, but that you can tolerate it. And so people walk away feeling much stronger about themselves.
But that's the essential idea, isn't it? That you believe that by encouraging people to confront the source of their anxiety, they'll build what you call self-efficacy. What does that mean?
The belief that you can do things.
What if someone in this room has got a friend or relative whose life is limited by a kind of crippling, I'll come to in a second, crippling anxiety, and they find the thought of someone like you helping them to confront it absolutely terrifying, and they refuse to come to treatment?
So I would talk to them about the evidence, so find some websites. So there's the International OCD Foundation, if it's OCD, that you can get information to give your friend. You could say that you'd go to the first session with them if it would make it helpful. And then, of course, the therapist will probably tell you you're not allowed to come back after that, but to get them there. Talk with them about what they need, the ways they... so I'm assuming that with Julie's husband, he just wasn't mean about it. So talk to them about, how do I need to tell you that I'm not going to help you anymore? If I see you doing a ritual, you probably don't want me nagging at you. So how do I tell you, oh, that's a ritual. You might want to stop that. Go undo that ritual. Go put on some dirty clothes. So asking them the way they need you, that it feels supportive to them to help them get through this.
In Julie's case, there weren't children in the family, but I'm wondering if you have clients who have involved their children in rituals, and if so, what help can we offer those children who are in such situations?
I haven't had that particular case, but I have had, let's say, a kid who comes in and then his mother might also have OCD. So my advice is, well, I can't help the kid if you're going to be doing your ritual, so you need to go find your own therapist to get your own help, so that you're not maintaining your kid's OCD.
I wonder, if I make this as a comment, and anyone who wishes to comment on it, but I wonder if we fail sometimes to ask, are there children at home, and see if there's anything we can do to help children when there are adults with mental issues. Would you like to comment on that? And then I'll come to Neil's, our third panel. Can you come out the front, do you mind? Just so I can keep you in the light. Just come over to the right. And this is Liz, who's also offered to share her experience. But what was your question or comment?
I was just going to say that my daughter actually helped me. She still stops me from completing rituals. She'll point out when I'm behaving pathologically rather than normally. So I feel an incredible sense of responsibility for what I put her through as a child, and she was the most helpful. I have bipolar disorder as well, and she was the least judgmental. I wasn't diagnosed for probably, until I was 53, I think. So we lived a long time with me behaving in a reckless and rather unfortunate way from time to time, and she knew what to say to me. She was always there for me, and she instilled some wisdom into a really crazy life. So at the same time that I feel that I did her harm by not being a well mother, she gave me the greatest gift that anyone could by understanding me and accepting me exactly as I am. And I think that's another thing, that acceptance, that sort of support. When I was trying to get better, what I found helped most was people who didn't judge me and who just were kind. And I know there's the theory that kindness isn't always the best thing, but for me, because I'd been so vilified for what was wrong with me, I'd been a really high achiever, I'd been a successful businesswoman in a relatively small place, and suddenly I became this person that people crossed the road to avoid because I wasn't who I was mad. And
can I just come in there for a second? How would you describe what anxiety is?
I agree, it's that overwhelming sense of dread that something awful's going to happen, but it's fear as well. It's just all the most undignified, unpleasant sort of feelings you can imagine in a toxic mixture that you don't necessarily, don't have any control over, and you can see that the thing that's disconcerting is often you can see that the way that you're behaving and feeling is crazy, but there's just no way of stopping it.
I'll come in because we had a quick conversation before we started, and Liz said that you feel you have a number of mental health issues that you could talk about, but obviously tonight I want to focus in on anxiety. Were there any physical symptoms aside from thinking, like?
Well, yes, I mean...
How did you know you were anxious? What else was happening?
Well, I had really, really severe panic attacks that were back to back, and that would make me feel very sick afterwards. I disassociated.
What does that mean, disassociate?
I felt constantly that I wasn't present, and I'd said from when I was as far back as I can remember, I used to say to my mother, I don't feel I'm here. And I'd even say to clinicians much, much later in my life, I feel like I'm not here. And it ignore it. You know, it was like I hadn't spoken, so I felt even more disassociated.
So what helped you? I heard diet, yoga, education, and you did try medical doctors, and I think you also had psychotherapy. But if there's anyone here who's identified with what you're saying, what would you offer them as information about the 2 or 3 things that really helped you?
Well, the thing I'd say first is that medication is definitely right for a lot of people, but it so happened it wasn't for me. I couldn't tolerate anything. It actually made me worse than I was without it. So I had to find alternate routes. I enrolled at university one day when I was feeling completely manic and I'd seen my therapist. I left and went to a life coach who was teaching creativity. And because I'm an artist, that's what I felt like would help me. And I came away from her and I thought, my God, if I could do that, you know, but I don't have a degree, so I can't do it. So in my manic sort of state, I thought, I'm going to go to university. So I approached the University of New South Wales and happened to speak to somebody who was incredibly encouraging. And I'd been excluded from a university because I had undiagnosed bipolar and just didn't put anything in my exams, so they kicked me out, which for a high achiever was the most galling thing you could ever imagine. So anyway, I got into university, did my fine arts degree.
And how did that help?
Well, I think art particularly is, it's known to be therapeutic. And for me, if I could get over the procrastination and the fear and the anxiety and once get started, painting and creating was so soothing and the best thing I could be doing.
And also, it is a culture and a group of people who have a high tolerance for eccentricity.
And yeah, exactly. And the head of the art school said to me, you would be amazed if you knew how many people were walking around with the same thing you've got. So we were all as mad as each other, or most of us. And
tell us about yoga. What role did that play?
My psychiatrist, I have a psychiatrist who's fabulous because he supports me not using medication. And he supports the use of yoga too, because not only are you having the benefits of exercise, but it's something that you have to be in the moment. You can't be thinking about all your other stuff. And for me with OCD, occasionally when I do yoga, I do actually do my rituals. And on a day like that, I think, my God, is it never going to let go of me? But for the most part, it's very helpful and it's really changed my life.
And the one last thing, the diet. You mentioned diet. What's the significance of that for you?
I went off gluten and sugar, and that I found them transformational, particularly the sugar. I'm celiac, so I have to not eat gluten, but I can tell that if I eat either of them, my anxiety level will go up instantly. But sugar, I would say to anybody, if you're anxious, don't eat sugar of any description.
Look, thank you. If people could turn off their mics, I'd be grateful. Thank you. I think I want to come to in 1 second. A quick word on exercise. What's the value of exercise in dealing with anxiety?
I think it's a great foundation. So you need to live a healthy lifestyle, go outside, exercise. For me, yoga may be helpful for somebody, but another person may be lifting weights or running, so do what works for you. But if you have moderate or severe anxiety, you're probably going to have to do something on top of that.
And could you just pass the mic to Vladan? The key medications, just in a nutshell.
That's a big topic.
You've got to do it in a nutshell.
Okay.
Because we're going to the social determinants of health in a second.
Okay.
It's got to be close to your mouth too.
All right, yes. So there are several groups of medications that are used for anxiety disorders. The most commonly used medications these days are antidepressants. The second group are benzodiazepines. And then, of course, there are various other medications that I don't have time to talk about. So these are the two main groups.
And we just heard from Liz that who tried medication that she didn't feel it worked for her and that other things have. And you've mentioned two very different kinds of medication. So as a clinician, how do you determine whether medication will be useful and what sort to try?
Okay, so one of the key factors, at least in my practice, is the severity of the problem. Usually, the more severe the problem is, the more severe the anxiety is, and especially if there is a co-occurring depression or other mental health problems, these people usually need medications. So the severity of the mental health issue is one of the key factors. The second factor is patient preference. I very much respect whether someone prefers a medication, psychological therapy, or something else, or a combination. So that's another really important factor. I could go on and on. One I think very important factor is any history of previous treatments with particular medications, because many patients, when they come to see me, already have an experience with some medications, and sometimes those experiences are good and sometimes they are horrible. So that very much guides me as to whether I should recommend the medication or not, and which medication would that be.
And what we're trying to do tonight is not to take a position on what is or not a good treatment, but rather to hear about the whole variety of what is available. I'm going to come to questions in just a moment, but I first of all want to introduce our third panel member, Professor Niels Boos, who's a professor of mental health nursing at Sydney University, where he does a range of research, and he's also involved at St Vincent's Hospital and St Vincent's Private Hospital, and is the leader of the Centre for Family-Based Mental Health Care. Before I ask you a question, do you want to comment yourself on what you've heard so far?
Yes. Listening to you talk, Julie.
Really close to your mouth and throw your beautiful voice.
Listening to you talk, Julie. I was. Your description of your relationship to your husband was really touching, and I felt a bit embarrassed that I actually started giggling a little bit from you waking him in the middle of the night. But the thing that struck me was how crippling on your life your situation was, and how bound to your house you must have been just stuck there for years, and what the level of further agony that must have inflicted on you and your relationship. The thing that I would like to comment on is related to you said something like, I was trying to keep it a secret. And I think that resonated very well with me from what I'd heard before, that a lot of people who suffer from anxiety, from worry, from stress, from depression, that whole group of psychiatric symptoms that are sort of linked more or less. It made me think about how much work you have to put into keeping it a secret from the rest of the world, and how much effort you would have to put in order to legitimize your problems to the rest of the world. Because it's an invisible disease. It's an invisible, maybe not a disease even. Maybe it's invisible to other people, unless they see you stuck washing your hands and you can't get out of it. But to most people, I would have guessed that you, this is just me imagining it, I would have guessed you were a superwoman in concealing your problems to the rest of the world. And I think it sort of reflects that problem, that it's hard to go out into the world and say, I have a problem, but you can't see it. I need special attention, but you can't see it.
And Niels, can I ask you, my understanding is with your research, one of the things you investigate is how people understand their own experience and how they explain it to others. Can you explain why that's important and how that leads to helping people?
It's important because I guess in particular mental health issues are stigmatizing, and stigma is the situation where you cannot really accept the story you tell about yourself. You really cannot acknowledge the story you're telling yourself about yourself. And it's also that you don't think that other people acknowledge the story you're telling about yourself. That's stigma. It's when you can't stand your story about yourself. And that was the thing that struck me when Liz started talking. It was really about I guess the road to recovery, where you experience something's wrong in your life and you try intuitively to explain what's wrong with me. How come I have these issues? And you start to repair it. You start to ritualize. You might start to drink. You might start to take up yoga or buy crystals or believe in astrology or go to a doctor. You will make all sorts of assumptions about your mental health and make hypotheses about what's wrong. And I think talking about an issue such as anxiety, it's such a broad human experience that I think for me it's very important to acknowledge that we can have a lot of very different hypotheses and a lot of different strategies for what helps. And I really like that you say, well, when would I like to suggest medication? Well, it depends what works for this person. Not just now or in 3 weeks, but in 3 years, because it needs to be a solution that continues to work and that's acceptable for that person.
Can I just ask, I guess, linking it to the path to recovery, this question of if I decide to get professional help, who do I go to? And is it right to think, do I need my GP, a clinical psychologist, a psychiatrist, a sports person, just a counsellor with a certificate from TAFE? So does the nature of the qualification matter? Or when I listen to you, I think it might be more relevant that I find someone who can help me develop a recovery story about myself and help me to actually recover. And so it won't matter so much their professional background. Help me.
To some extent, yes, but in some situations where people are so crippled by their symptoms, they need an interdisciplinary approach. They need help from a lot of people and a variety of people. And I don't really care if I have to work with a shaman as well as a medical doctor or a psychologist or a religious leader. It depends on who are the persons that are important to solve the problem that we tend to agree on that's in the room. So that's to me it's not important whether I start one place or the other, but rather to find the people who will open up the situation so that you can work with it.
I'll ask him one more question, then I come to you. Are you mad? This is me acting like a devil's advocate. I want to be safe. At least I know if I go to a doctor or a clinical psychologist, they've got a registration board. Someone's checked they've got their qualifications. There's somewhere I can complain if they do something that I'm not comfortable with or whatever. Whereas if I go to a shaman, well, what do I look them up? Google shamans here in the eastern suburbs. There's probably a few. But what trust do I have that they're going to be safe for me? You can see my point. I've put it a bit loudly, but what would you say?
Well, medication is tricky because a lot of it doesn't work on very many people. Antidepressants are not very efficient, and a lot of them are very difficult to stop taking. Again, you'd have withdrawal symptoms. So any treatment or any intervention you try has got risk related to it to some extent. And I guess that if in doubt, bring your best friend, bring your partner, bring your family along to see the person you find trustworthy and find out whether it's something that works or it's just someone who wants to set you at risk or get your money. Of course that's an issue.
Thank you very much. We'll come back to our panel, but questions or comments from the audience? Would anyone like to ask a question or make a comment? Just wave your hand and, of good, it's the back row, this is so important because I'm 63 and I've got an arthritic right leg. And I've been told it's terribly important for me to lose weight and increase my exercise. And therefore, the back row is the best thing. That's called ad-libbing while you make it. I'm now treading on people because my sister's a podiatrist. I'll distribute her card later. Now, where was the person? Thank you, sir. And I'll hold the mic if you could just introduce yourself and tell us your question or comment.
My name's Ron Freeman. I just wanted to ask, is anxiety primarily a genetic or inherited condition, or is it primarily environmental, or both?
Thank you. I'd love a quick answer from each person.
Okay.
You go first? Yeah.
Okay, my quick answer would be, if I had a straightforward answer to your question, I would probably be a candidate for Nobel Prize. So it's both genetic and environmental, developmental, and so on.
And could I just ask you, Doctor, what does genetic mean? When you say it's part genetic, what does that mean?
Okay, so that means basically what you inherit from your parents, what you're born with.
And what does environmental mean?
Oh, that's much broader, of course. It means, well, first of all, the family circumstances in which you grow up, and even prior to that, issues of attachment with your primary caregivers. So then family, then school, then larger community, then various experiences that people may have, such as traumatic experiences, which can, of course, cause anxiety and all sorts of other mental health problems. So environment is much broader.
Thank you. And Melissa?
Yes, I would also say it's both. If you look at twin studies that can answer this question, looking at how much it's somebody's environment or genetics, depends on what disorder you're looking at, but it's about 50-50 usually in those studies.
And just before I come to Neil's, twin studies, explain why they're so significant and important in understanding questions like genetic and social factors, which is most significant.
So twin studies can look at twins reared in the same home or reared apart, so you can separate biology from environment. It can also look at monozygotic versus digozygotic twins to also tell you more about the genetic factor.
And just explain what those two types of twins means.
So identical twins are monozygotic and not identical twins are the other kind. So they share less common factors genetically.
Thank you. And Niels, what would you say?
I think it's unfair that I come last here.
No, I'm going to come back to you because when we met this evening, you said that you believe it's important to think about anxiety as a social problem that requires social solutions. So that leads me to think you think environment is important.
Absolutely. The point that's very important to make is that the way in which we've talked about anxiety tonight has very much been focused on the individual with the problem. And I think when we talk about what's genetic and what's environment, that looking at mental health overall, we know that the strongest determinants are actually social determinants. It's about poverty, it's about socioeconomic influences on people's situation, and it affects families and communities from even before their newborn are born. And if we want to truly address some of the core mental health illnesses, we have to look at how we can start, you might say, repairing the social cohesiveness of our communities and our countries ultimately. So it's about supporting social communities and combating poverty, for instance, and giving people opportunity to recover socially as well as mentally.
Can you just remember, I want to ask you about that poverty question later, but I want to give the audience a chance. Do you have a question, sir? I'll come to you. Is there anyone else just around here before I go to that gentleman? I'll come to this lady first, sir, and then I'll come to you.
No one's mentioned the effects of stress in your life on anxiety. Does that play a part?
Thank you. Do you want to go, Melissa, first?
Stress definitely has an impact. So in order to determine if you have an anxiety disorder, it would be when the stressor disappears, is your anxiety still there? And then you might have a more significant problem. But for example, when I work with OCD and somebody gets CBT, and I specifically do exposure and response prevention, is I always teach them, when you learn this, you learn it within a context. So if you're only carrying out treatment in the morning, you're going to be better able to retrieve it in the morning. Same thing with if you're having an easygoing time in your life besides your anxiety, you will learn it in that context of everything's going well for you. But then if 2 years later you lose your job, someone dies, you get pregnant, they can even be good stressors. Often OCD or other anxiety disorders will come back because it's a new context and you might start avoiding. And so you need to relearn those, what you learned during therapy the first time, again in that stressful context.
Would either of the gentlemen like to respond to that question about stress?
I could just emphasize what
Keep it close to your mouth.
Yes, what we have heard. Stress has a huge impact. I have a bit of a problem with the term stress because it's used so loosely.
So what does it mean?
Nothing. Well, I'm sorry. It means everything and nothing. It's certainly it usually refers to some external events that impact negatively on the person. But of course, it doesn't have to be external events. It can be one's illness, physical illness, that can be conceptualized as stress. So stress is really anything that affects your well-being in a negative way. Let's put it like that.
One of the things I'm struggling with is that your original definition, if I remember, was that you distinguished, in a sense, the normal response to stress of fight or flight from anxiety, which I think you described as persistent dread. I'm just doing that from memory. And so are we talking there about a continuum of the same thing just getting more intense? Or is there something actually different about persistent dread from the normal anxiety or fear you might get on a cancer diagnosis or your child has a serious illness?
See, that's an excellent question, and I don't have a straightforward answer. Again, what I see in clinical practice is usually a mixture of these two presentations. So I see people who have more of a fear reaction. For example, a typical example is a person experiencing a panic attack. That's a very good human model of fight or flight reaction. These people feel vitally threatened, and they feel that they have to do something right now. If they don't do something right now, they will die. And doing something right now is usually escaping. So again, it's usually flight, not fight. But these same people who have panic attacks, at other times, they also have that anxiety, that sort of dread that is difficult to describe, that they have trouble formulating. They may say, I'm concerned how this is affecting me, what long-term consequences will be, etc. And again, sometimes it's a little bit more understandable. At other times, it's quite vague. So the same person can experience both types of anxiety, or both anxiety and fear. Let's put it like that.
Look, thank you. This gentleman.
Thank you for an excellent discussion. I actually have 2 points, if I'm allowed to. The first one, just based on the first question that was asked about genetic and environmental. I was last week at an excellent talk at Sydney University given by John Mattick from the Garvan Institute on genomic medicine. And in the course of that talk, he mentioned some of the research that they're doing, what it's proposed, to look at genetic or genomic factors that play with reactions to drugs. So some people will have a positive reaction to a drug, some will have a negative, and some will have no reaction. So that's one aspect. I raised the issue of the similar question with regard to food, because some people are more resilient or resistant to certain foods, and some are more sensitive. And hypoglycemia has definitely been linked with anxiety. I know that for certain, that from people I've been involved with and from people I've spoken to in this field. So sugar was extremely important. I was glad that was raised. That was my first set of questions.
Just take that as a comment, eh?
Yeah. If you could respond to that, you know, how you feel genomic medicine will refer. My other question, my original question, was some people with regard to anxiety, well, actually with any illness, when it comes to the questions of recovery, some people actually subconsciously don't actually really want to recover because there are factors in their lives that have made it advantageous for them to continue with their disease. So we find some people that are very resistant for decades have the same problem. They go to specialist after specialist, drug after drug, and it's actually, it turns out sometimes, I don't know how often this happens, but it does happen that some people are actually, you know, benefiting in some level for their disease subconsciously. So I wonder if that's also something to be taken into account. When we always speak of recovery, yes, people say they want to recover, but they don't always behave as if they want to recover.
Look, thank you. I might go to the second one first, if I may, and I'll come to this gentleman next. Who would like to comment on this issue of people who at some level don't want to recover? Their identity or their story, perhaps, Neil, is that I am a person with a problem and that's become their identity. Who would like to comment on that one or respond? I'll come to you in a second, if I may. I'll just come to our panel. Yeah.
I would just say it's very important. So if I'm working with someone and they're not getting better, it's trying to explore what are the possible reasons, and hopefully would uncover that. I have worked with someone who had OCD and was also seeing a psychiatrist and thought that psychiatrist was attractive and didn't want to stop seeing him because she enjoyed the visits. So working through how can you get those needs met elsewhere so that you no longer feel like you need to have that relationship.
Thank you. Yes.
Just to add to this, there is a phenomenon described long time ago as secondary gain, and that means that, you know, people who suffer from an anxiety disorder may be unwilling to get better. Let's put it like that, because they have some benefit from their condition, right?
Could you give us an example?
An example would be a partner who is always obliged to go with the person with agoraphobia. People with agoraphobia are typically afraid of leaving their home, going anywhere, especially to crowded places like this, you know, cinemas and shopping malls, etc. So these people usually require someone to accompany them. It's usually their partners. So in some cases, and I have certainly witnessed this in my clinical practice, these patients are unwilling to give this up. This sense of control, they are in a way controlling their partner, because their partner almost always accompanies them whenever they go out.
Niels, would you like to comment?
I'd really like to know what this, I didn't get your name, this gentleman, what he thought about what is recovery. What you mean by recovery in your question?
I guess it's an open question. The term was used here, so I'm interested in how you're using the term. I guess it has a very wide range of interpretations. If you say recovery, one would assume that, you know, some people was functioning well and then got sick and then wants to return to that well functioning, but some people perhaps never functioned well. So what does recovery mean for them? It's transformation for them. For them, it's something that they've never experienced before, perhaps.
Did you want to comment, Neil?
Yeah, I think it's quite tricky because it's become a bit of a specialized term, you might say, within the mental health system. In lay terms, to recover just means you become well again.
Can it mean that you enjoy life and you're able to do meaningful things and form a relationship?
Well, it means that you can...
Freud said something to do, someone to love, and something to look forward to. I'm just coming up with some answers for you. What would you call it, seriously?
I would say that you can lead a meaningful life within the boundaries that disability may impose on you. That's one way of looking at it. But when it comes to the actual term, it grew out of American AA-inspired psychiatry survivors who said, if you want to truly recover, you have to go through an individual journey where you have to fight your way back to your social position. You have to reclaim your identity. And that means there's a lot of hard work in it for you, where you go back and say, this is my place, I can go out, I can share my life with other people, I can do what I want to do, because despite of the limitations. So talking about recovery, the broad version is just to get better, but the narrow version of talking about recovery is to put up a fight and reclaim who you are. And that, I think, is very important when you talk about anxiety, because there's so much work about finding out who are you and what you want to get out of your life, and then going through that journey with all the repair and all the negotiation about who am I in society.
Look, thank you. I'm going to come back to genomics, if I may, because this gentleman's been waiting a long time, and then I'm going to go to a couple of people down there. I never let go of the mic.
Thank you. I studied some undergraduate psychology.
I'll hold it.
I studied some undergraduate psychiatry at Sydney University about 40 plus years ago. I don't recall there ever being... I recall there was a thing called anxiety, but it didn't seem to have components of OCD. And it just seems like what you're describing tonight is 2 or 3 disorders, and it seems like anxiety alone isn't enough to make you sick. It might make you afraid, but you see, you're talking about the people who've been talking tonight. They're very brave. I thank them for their words, but they seem like they have more than one disturbance. Am I correct in this observation? The nomenclature may have changed a bit over the years.
Thank you. Do you want to go first, please? Do you want to go first, Melissa? Go.
Yes, how we categorize anxiety has greatly changed over the years. So I wasn't around 40 years ago. But right now, what we have conceptualized as anxiety when I started my training has now split into 3 different categories. So in the anxiety disorders category, we had post-traumatic stress disorder, so you had a life-threatening event and now it keeps troubling you. We have social anxiety, where you're afraid of negative evaluation in performance or public situations. For kids, we have separation anxiety, you're afraid of being around a caregiver. We had OCD. OCD is now in its separate category with hoarding disorder, trichotillomania. Actually, that's an impulse control disorder. We have PTSD, used to be an anxiety disorder, now it's in a trauma category. So it depends, I guess, who you ask, but for me, all these things are still anxiety. It just depends, what is the content of your worry? Is it about people? Then it's probably social anxiety. If it's about unrealistic fears, OCD.
And 40 years ago, this would all be subsumed under the term neurosis. that many of you may be familiar with that. Many of you may be familiar with that term. This term is now considered obsolete. In my view, that's wrong, but that's another story.
Is it worth quickly saying, and then I'll bring you in, that there's a thing called the Diagnostic Statistical Manual, the DSM, that, as I understand, is developed, published by the American Psychiatry Association, but many international professionals and clinicians have huge debates and arguments about definitions, and then there is an agreement, but they have updates, and therefore the definitions and the recommended medications or not medications vary with time. So for example, the hoarding disorder has relatively recently gone into the DSM-5, so it's the 5th volume. So it didn't even exist in the 4th volume. So, sir, I guess over 40 years there'll be a lot of changes. I've got 2 more people in the audience I want to bring in, but did you want to respond to that question about different names, different definitions? How broad are we defining anxiety and what comes under that umbrella?
No. The thing that struck me was that you can have just a single, you can suffer just from anxiety, from generalized anxiety, and nothing more, and it can be completely crippling. No OCD, no nothing else, just general anxiety. And it's heartbreakingly troubling. I don't have the words in English, sorry.
I could just add to this. I think it's wrong to look at these diagnoses that you have mentioned, that you have referred to, the DSM cross-sectionally at any particular point in time. What we need to do is look at people over time, longitudinally, because the form of anxiety often changes over time. So somebody who in their teens was diagnosed as having social anxiety, in their 20s may be diagnosed as having panic disorder or social phobia, in their 30s or 40s may be diagnosed as having generalized anxiety disorder. So going back to some of the questions, what's underneath all this is a propensity towards anxiety or vulnerability. So there are some people who definitely have that propensity. Now, how it will manifest itself depends on the age, obviously, as I have mentioned, but also on a range of other factors.
My friend is wanting to comment for some time. Yes, do you want to stand up just so we can capture you?
What I wanted to say is I'm a prime example of what the professor's just been saying about anxiety changing over the years, because I started with separation anxiety, and then as I got older it went from one thing to another, and I felt like the anxiety leapfrogged according to what was going on in my life, and I didn't realize it had necessarily something to do with age, although I know that during menopause, pregnancy, there are all these sort of impacts on the body that make a difference. And really, if I could just say also that there was a mention about severity and taking medication, and I didn't leave my house for years because I was so bad, but the thing was I still couldn't take medication. And with reference to what Niels is saying, it's a really lonely thing to have anxiety because it's so stupid, a lot of what you feel, and there's an element of weakness to having illnesses like this. The perception is really unkind a lot of the time, and that's why I like to speak at something like this, because people say to me, you don't look as though you have a mental illness, and I don't really know what we're meant to look like. It's just an unfortunate thing that happens to some of us. And I started off, what I wanted to say is I've had every type of anxiety you can imagine, and I emphasize OCD because it's the most unpleasant thing to have. Constantly I've got it going through my head because I have mental compulsions, and so nobody knows what I'm feeling, what I'm doing. I have to go through doorways in a particular way. I have to, maybe put my clothes on in a particular order, but only my daughter and people really close to me will know what's going on. We have to put this face on in the world, and it's really difficult. And as I say, it's incredibly lonely. And compassion and understanding is the best thing that we can possibly do to help each other, and perhaps in a communal way, stop the pain that people are feeling in isolation.
Thank you so much. Thank you. Do you want to comment? Did you want to say something, Jill? Yeah. Do you mind standing up? Just because they're filming up the back. Yeah. You're right.
I just wanted to say to Niels, thank you for your comment. And yes, it is exhausting, and it's exhausting as well as physically, mentally, but trying to hide it from people. And I think, unfortunately, anxiety disorders are seen as trivial. They're just something silly. You just need to get over it. And if I say I've got OCD to someone, they go, oh, that thing where you hang the same colour pegs on the clothesline. Well, it's so much more than that. So people don't tell, and I went through my life thinking I was the only person. I may have sat next to someone at school who had OCD, but they were hiding it as well. So we do spend a lot of time trying to hide it because people do find it trivial and laugh at you.
Ladies and gentlemen, we've got 20 minutes left, just to give you a sense of time, and I want to introduce you to two people who are involved as active clinicians and who have an approach to assisting people with anxiety. So I'd like to introduce Renee Mill. who's a clinical psychologist and author, and is the principal of Anxiety Solutions CBT, a psychology practice in Edgecliff. And the thing we wanted to focus on was that you've written a book, Anxiety-Free, Drug-Free, based on 10 sessions to do with cognitive behaviour therapy. So what are you, I know this is a terrible journalistic question, but in essence, what are you trying to get across in that book, which I understand is a bestseller?
I just want a few words before I get into the question. I deal with a population that probably hasn't been touched on tonight. I deal with what some people call the worried well. I do have some people who are really not well, but they're very high functioning. And I think you were touching on it. There's some people that really function quite well, but they are in agony. And very often it's just worry, rumination, so they could be functioning as professionals, but sitting in boardrooms, not sleeping at night is a big function, being nauseous or sick often. So you can have people who are suffering from anxiety who don't need to see a psychiatrist, who don't need medication, but actually are afflicted. The second thing is that a lot of people don't qualify for public health, and so I have to say that being in practice, dealing with people who are suffering, and with Medicare, which on one hand is great, but I really saw the need to also fit in with people's budgetary constraints and time limits. And the third thing, I'm originally analytically trained, and so I was used to very long-term therapy before CBT, but people just want help. I'm suffering, I feel uncomfortable in my body, I'm having panic, what can I do? And so, in essence, I developed a program where people can really just deal with their symptoms as a starting point. Often it needs to lead into other things as well, but to really, what I say, soothe the primitive brain, use other parts of your brain, be able to be calm, be able to function. And the big message of it is there's a lot you can do to feel empowered, to be bigger than your symptoms, to take ownership of your thoughts, your body, of your physiological reactions, and to really move on, some of the words you used earlier, to enjoy life and to be happy and so on. Sometimes it's more complicated and then one needs to go into other things, but often that is the starting point before a person can actually be a good parent or be available in a relationship.
And could you give us a couple of examples of the sort of issues someone may bring to you and the sort of strategies you might ask them to explore?
Well, one of them actually is, no one's really mentioned fight very much. And actually my latest book, I just want to add this, is about parenting without anger. So often parents feel they're in danger all the time. They're worrying about their kids, and it comes out as having a short fuse. So often we'll use the same strategies as we use for anxiety to be calm. It could be self-care. It could be eating properly. Someone mentioned sugar, so some mothers don't eat all day. It can be very simple strategies, mindfulness, changing your thoughts, reframing a situation. That's a common one. Another common one we'll deal with is exam stress. So kids who just have meltdowns even now before the NAPLAN, but I see a lot of year 11 or year 12 students who don't want to come in and examine anything, but they need strategies of how to get through their exams. Those are very common ones. And a third one is dealing with professionals who have what we call the imposter syndrome. And so they're working, but actually they're petrified they're going to be caught out. And again, you would never know it. They're hiding it very well, but at an enormous emotional cost.
Niels has emphasised, if I say it correctly, that this is not just often individual issues, but they're social issues. And you've mentioned helping children with stress with exams. What can schools do as communities to reduce anxiety across the population, as well as helping the students with more severe anxiety?
Well, there's so much that could be done. I know of some schools who are bringing in things like mindfulness courses into the schools. I think there needs to be more awareness that kids are suffering. Again, no stigmatization. That's a huge thing. And the bullying is actually increasing anxiety. The social media, people are either addicted to their phones, there could be education around that, but also helping in the social relationships, because that's a huge source of anxiety, how the kids bully one another and exclude one another.
Just before I let you go, that expression, worried well, I've always seen it as a kind of pejorative word, a negative word, a put-down word, a cruel word. You know, we've had a lot of talk about the need for kindness and compassion. You know, what do you think about that term, the worried well?
Well, that's why I mention it, because even when it's mentioned to me, it's like, you know, I work with those kind of people. But they are suffering, and it is a put down. And a worry is actually, I'll call it an affliction. When you're worried and you can't sleep. I mean, I heard recently of someone who's following her, I didn't know there was an app to follow flights. So when her children travel, she's tracking the flight. Now that's severe. Now on the outside she's fine, but she's so worried that on her own level, although she is functioning, she's not functioning, she can't free her mind. So yes, it is a put down, and what people do need is sympathy. Often, you know, they need to find the right kind of treatment, but they are still suffering on a daily basis to get through the day in a calm, internally managed way.
Thank you so much. Thank you. I'd like to introduce you now to Lisa Champion, who's a university qualified counsellor from the Australian Catholic University and also a graduate in exercise science, and she's in private practice in Pyrmont. I wanted to ask you about emotion-focused therapy, but is there any general comment you'd like to make about what you've heard so far?
Well, first of all, I just want to say thank you to Renee for your comments, because I was going to say the same thing, that I think we've had some wonderful discussion about the larger perspective or the more serious anxiety disorders, and we haven't spoken as much until Renee's comments about the worry that goes on for many of us, that where we are still functioning well. And that does tend to be the type of client that I see as a counsellor and psychotherapist. A client who is suffering from just a persistent sense of worry that is causing them perhaps not to sleep well and all of the things that you mentioned.
And so you were originally an exercise therapist, and you would be the same as me. There is endless articles covering research that indicates that exercise is good at helping to prevent or cure almost anything, but certainly mental well-being. What made you move into a deeper level? I mean, is exercise still part of how you try to help people, or what more was needed?
There are two things I'll say about that. The first thing was, in my work in the fitness industry, I worked as an exercise therapist, helping people with chronic pain issues. And the thing that I noticed there was the emotional toll of chronic pain. And fear and worry are emotions. And so I became very interested in trying to understand more about people's emotional experience. And that is what ultimately led me to go back to university. And initially I thought, oh, I'll just go and learn a little bit about how to work more with the mind, but became quite captivated by it, and led me to then study further in the area of emotion-focused therapy.
So what does that mean?
Emotion-focused therapy prizes people's emotional experience, and as I said, fear, hurt, sadness, worry are all emotional experiences. And it's very interesting, what we think about in emotionally focused therapy is, what do you do with your emotional experience? So if you have an emotion like fear, you're scared of something, perhaps it's performance anxiety at work, perhaps it's a fear of extremely high expectations, perhaps it's fear of being negatively evaluated, or different kinds of things, then what do you do with that experience? So if you're feeling worried and fearful about something, do you bury it down? Have you been given a message that says, man up and just get over it and, you know, face your fears? Or are you able and have been encouraged in some way to have a conversation about your emotional experience, about your fear, and to have that conversation be held with someone who is caring and compassionate and empathic and very deeply interested in your experience, to help you try to understand how those things may be influencing and be drivers for something like anxiety or depression or whatever else it is that you're suffering.
And are there, if you could just come forward a little bit, are there particular practical strategies or techniques that you offer someone once you've deeply engaged with their emotional experience?
Absolutely, and I think that one of the things that we do, there are many things, and we haven't talked tonight about the power of breathing, which is very, very important in dealing with anxiety, but it connects with one of the things that we work with, which is tapping in to your body's experience. So I want to do something with you very quickly right now. Is that okay? Okay, so just try this. Just take one of your hands and put it on your chest. And just take a moment and close your eyes, if you feel comfortable, or look down if you don't, and just notice what's happening in your body. Do you feel relaxed? Maybe you notice a little bit of tension. Maybe you have a sensation in your body. It might be a churning or a tightening or a heaviness or a lightness. So just notice whatever it is and just let it be there. And then just gently start to take a couple of deep breaths. And just imagine that your hand is full of warmth and kindness. And it's helping to settle whatever that feeling is and connect with that feeling. And then when you're ready, just open your eyes and notice how you feel. So if we had time, I'd love to kind of hear what your experiences are. But for people with anxiety, you'll often hear, I have a tightness in my chest. My throat is constricted, which is I can't speak. I've got a churning in my stomach. I feel tension in my shoulders. And so one of the key things that I find is really important is to help people become aware of the signals that you're getting from your body. And then what does that mean? What do you need? Do you need to take some time to go into a mindful place, to take some deep breaths, to calm that sensation down? Do you need to go out for a walk and be out in nature? Do you need to go and do a hard workout because that might work for you? There could be lots of different things. Do you need to go and have a cup of tea with a lovely friend? Whatever it is that helps to calm that. So we can learn a lot from our bodies, and that's one of the things that we tap into in emotion-focused work.
Thank you. Just before I let you go, because we're very close to finishing, we've actually met previously in a women's walking group called Wild Women on Top, and they raise money for the Fred Hollows Foundation by going on long walks, among other things. But you mentioned nature there, and I thought it was just worth underlining that, because I understand there is some research to indicate that being out in nature can be soothing. I mean, that was certainly the experience of a lot of people who go hiking and bushwalking and so on.
Yeah, or even just going and sitting in a park and listening to the birds and taking a few deep breaths. But again, we've talked about it, I think everyone has mentioned that what's important is what works for you. So if you're not a nature person, and you might feel better sitting in front of a warm fire in the winter with a rug around you, or
going to New York.
Yeah, that's right. Or, being in a busier place with that's more social. And for some people, it might not be nature. It might be being with friends and laughing and having social time that helps you feel better. It's what works for you. But nature is very, very powerful.
Look, thank you very much. Would you give her a round of applause? Is there anyone thinking there's something really important they haven't mentioned, or you have a question you really like? Can you come and meet me halfway, just because of my wonky leg? Thank you.
I've just got a question about anxiety from parents falling onto their kids. And I'm wondering how you manage that.
Could you just explain what you mean by falling?
So if a person's generally very anxious or well-worrying, whatever that is, and I find that my kids are potentially falling into that as well. They copy the behaviors and whatnot, and I'm not an anxious person. My wife happens to be quite anxious, and I'm wondering how I can manage that from affecting my children's behavior.
Thank you. What a fabulous question. Can I hear from each of you? And this will be our closing words. Melissa, did you want to begin? Have you got a mic there? Yeah.
For your specific example, One of the things I would do if I was working with your wife is to talk about the things we've discussed today. So with debilitating anxiety, you are spending a lot of effort to control that anxiety. You're just doing it in an unhelpful way. So how about you use that energy to do something we know that's effective? So stop avoiding. And if you're having trouble believing in that, think about how much you love your kid and how much you want the best for your kids, and use that as some motivation to get started. And so to focus on that bond between the mother and the child, to encourage them to do something different about their anxiety, and to also help them, remind them that they are strong, even if they may not feel that way. They are spending a lot of effort being anxious, doing their rituals, avoiding doing other things, and to use that.
Niels, would you like to comment?
Yes, I was thinking more in terms of a concept that we're working on both at St. Vincent's and in Nepean is open dialogue, which is a type of family intervention where you bring the whole family and social network together to encourage people to talk about what they see as the problem. So you would bring a family of 4 together and some of their friends, and you would have at least 4 different versions of what the problem is. And then to start working in that space where you start to generate new understandings about maybe your wife's behavior, maybe your behavior, maybe the behavior that your kids are displaying and how they understand it. So I guess I'm thinking in increasing the connectedness between your family members and the social network, to ensure that we do not pathologize your wife, but rather not see one single person with a problem, but rather a group of people working on an issue.
Thank you. And
I would very much agree with my colleagues. And maybe just to amplify that, or to add that when I hear the term anxiety used by patients, to me it often means a tip of the iceberg. You know, something that's on the surface. People use the term anxiety very loosely, and oftentimes what I find is that there is something underneath that anxiety. Communication problems, people not understanding. So I'm talking about family units. So very often these are the issues that need to be addressed. So partnership problems, marital issues, how they relate to their children. If their children are teenagers and have again their own issues, rebelliousness. How that's all played up in that family dynamics, just what Niels was talking about. So it's really looking at the family from different points of view, and not just focusing on the symptom and saying my wife has anxiety, I have anxiety, my children have anxiety, and I'm hugely worried. My children will just, continue with that anxiety. I think there is a lot that can be done to address various problems that create that anxiety.
And we just have one more comment.
Thank you. So we teach emotion regulation, whether it's managing anxiety or whether it's managing anger. And what you can do is, when we teach a parent a strategy, the whole family can learn that strategy. For example, if you need to reframe something, the mother knows how to do it, and the whole family then do it. It becomes a discussion, and it's not fixating on just one person in the family or an identified patient. So there are a lot of emotion regulation techniques that can become part of the language of the family, and it's good for everyone, even those of us that don't have anxiety or are resilient. It builds resilience to actually go, I'm feeling my emotions rising, how can I regulate it, whether it's breathing, whether it's mindfulness, whatever, it becomes part of the culture of the family. And it's very, very helpful because we actually say that our brains are social, and one person's anxiety can set off anxiety in the other. So as one person starts calming down, everybody will and can participate in it. And it's actually very affirming for a family as well to have that language.
Thank you. And just before I hand back, yes, thank you. Just before I end the session and thank our panel, and Alan will come forward, if I may say, as a young person who grew up in a home where there was someone with great anxiety, what helped me was being actively assisted to get involved in my local church, synagogue, mosque, whatever, and also national fitness camps, so organised activities. In both those two worlds, I was able to meet a range of other adults who helped me learn different ways of living and to see how other adults lived. Because I think sometimes a child, if they're alone in a home, they don't know that there's another way to live. And so finding positive, socially positive group experiences that can build the resilience of the child by giving them broader access to a range of adults and peers, I think can be very, very helpful, if I could just speak as a child. Ladies and gentlemen, what an interesting discussion. Would you thank our panel in the audience and on the stage? And I hand back over to Dr. Shell.
And we also have to thank Julie, please. So for those who are on our mailing list, thank you for coming along. And for those who would like to be on our mailing list, because we will continue to have these sessions next year. The first one will be in March on respiratory and lung disorders, another serious problem in the community. And I think that from tonight we have to agree that they consider the ABS, Australian Bureau of Statistics, back in 2007 did a national survey, and in a 12-month period over 2 million people experienced some form of anxiety. So it's a very full house today. There's over 240 people here. So I think it's a big number, and thank you very much to our speakers for being here tonight, and thank you to all of you. We wish you a happy and healthy summer season, and hopefully we'll all see the new year in good health. Thank you and good night.